Continue with the next topic. My name is Carlos Torres. I'm a neuroradiologist. I'm professor of radiology at the University of Ottawa in Canada. And in the next 20 minutes, I will be talking about brain metastases. I have no disclosures. The objectives of this lecture are to review general aspects of brain metastases, to review the key imaging features that help us make the diagnosis of metastatic disease, and also to assess differential diagnosis, and to discuss the role of imaging in monitoring of treatment of patients who have metastatic brain disease. So up to 40% of adult patients with cancer are diagnosed with metastatic disease, of which approximately 25% involve the CNS. We have seen an increased incidence of metastatic disease to the brain due to improved treatments, improved surveillance with MRI, which have led to longer survival of patients. And metastatic disease to the brain is 10 times more common than primary tumors. So the most common primary tumors that metastasize to the brain, no surprise there, are going to be lung and breast CA, followed by melanoma. In 15% of cases, we're going to be dealing with an unknown primary, and hematologic tumors represent 10% of intracranial metastases. However, these tend to involve the leptomeninges. At the end of the day, metastatic disease to the brain entails a poor prognosis and is the leading cause of morbid mortality. Up to 75% of patients with brain metastases are actually completely asymptomatic, but when patients present with symptoms, the most common symptoms are going to be headache, seizures, and focal deficits, and this is usually due to the presence of mass effect, edema, and hydrocephalus that leads to increased intracranial pressure. So here we have an example of a non-primary lung cancer who presented with headache and papilledema on clinical exam, and of course there is an explanation for that. We see a large enhancing lesion centered in the right cerebellar hemisphere with associated mass effect and surrounding vasogenic edema causing tonsillar herniation and obstructive non-communicating hydrocephalus with imaging signs of transependymal flow of CSF. Hematogenous spread is the most common source of a spread of metastatic disease to the brain, or the most common route of metastatic disease to the brain. Basically what happens is there's going to be detachment of neoplastic cells from the primary tumor that are going then to navigate spread from there through the circulatory system into the metastatic site, usually at the gray-white matter junction. Why? Because that's where we have a lot of turbulent flow due to change in the caliber of the vessels, and at that point we're going to have extravasation of these neoplastic cells through the vessel wall into the perivascular space, and this is going to be controlled by the blood-brain barrier that limits movement of certain molecules based on the size and the charge of the molecule, and is going to control the metabolic microenvironment that is going to enable the growth and the proliferation of some particular cells. For example, in high chloride content in the interstitial fluid of the brain, there could be that enables proliferation of neuroepithelial neoplastic cells in the context of melanoma and squamous cell carcinoma. So as I said before, the most common location of metastatic disease is going to be the gray-white matter junction. As you see, most of the lesions are going to be localized in the cerebral hemispheres. The rest are going to be either in the cerebellum or in the brainstem. And here we have three examples of the typical locations, three different patients with metastatic disease to the brain. As you see, all of them located at the gray-white matter junctions due to this change in the caliber of the vessels that facilitates that metastatic cells are deposited in that particular location. Of course, we're going to deal also with increased permeability of the capillaries that leads to significant vasogenic edema, one of the hallmarks of metastatic disease, edema that tends to be disproportionate to the size of the metastatic deposits. Of course, some of the metastatic lesions have a fairly classic appearance. Here we have metastases from adenocarcinoma. These metastases tend to have a very low signal intensity on T2, and they show restricted diffusion with low ADC, and this is due to high cellularity and increased nuclear to cytoplasmic ratio. Okay, and what if we encounter hemorrhagic lesions in the brain? Well, we have to make sure that we are not missing an underlying lesion. We have to be very suspicious when there is an intracranial or parenchymal bleed in a patient who is younger than 50 years of age, when these bleeds are in an atypical location or they have an atypical appearance, and of course more so if the patients have no history of trauma, hypertension, or coagulopathy. So here we have an example of a patient who presented with this hemorrhage in the posteromedial aspect of the right cerebral hemisphere, and we see after contrast administration that there is enhancement due to the presence of an underlying mass in a patient with metastases from colon cancer. Here we have another patient with hemorrhagic lesions in the left frontal lobe. So it's not critical to try to guess the origin of these metastatic deposits, since all of these patients will have workup for primary tumor. But important to remember that up to 20% of metastatic lesions can be hemorrhagic. Of course, these are going to be the most common tumors to give hemorrhagic metastases. And also keep in mind that some of these metastatic deposits could be bright on T1, and this could be either secondary to hemorrhage or melanin, or actually the combination of both. What can we do to try to tease apart melanin versus hemorrhage? Well, SWI may be helpful. Here we have a lesion that is bright on T1, demonstrates enhancement, and when we look at the SWI, we see that only 2 areas show susceptibility artifact in keeping with hemorrhage. The rest is mostly melanin in this patient with metastatic melanoma. Perfusion, of course, is going to be very useful, and the CBV is going to be high in the area of peripheral enhancement of the metastatic deposit. However, we have to be careful because perfusion is not always high, and that doesn't mean that the lesion is not neoplastic. This happens mainly when there are blood products within the lesion. If we're dealing with a hemorrhagic lesion, this is going to lead to susceptibility artifact, and our T2 perfusion is going to seem that is completely normal. And here we have another example. This is a lesion that we've seen already in the right frontal operculum with high spontaneous signal on T1. And again, look at the T2 perfusion. The CBV is low. So are we dealing with a benign process? No, we have to be careful. And in these cases, what we do in our institution is we perform T1 perfusion. And you see here in the K-trans that there is increased permeability due to a leaky blood-brain barrier. So this actually was a hemorrhagic metastasis from melanoma. ASL and gadolinium enhanced perfusion are both very good. We see here in these 2 different patients with metastatic disease, both of them showing very nicely the increased perfusion. What else is important? Of course, to take into account the main differential diagnosis. So when we're dealing with a solitary ring-enhancing lesion, the most important thing to take into account is, are we dealing with a metastatic lesion versus a primary tumor? Why is this important? Because it changes management, of course. And we see in these 2 examples, ring-enhancing lesions, both of them showing very similar perfusion abnormality. So the patient on the left had a metastatic deposit, while the patient on the right had a glioblastoma. So what can we use in order to make the difference between the 2? Well, we know that both lesions are going to have a contrast enhancement in the solid component. As we've seen in the examples, both show increased perfusion. Both of them are going to show low ADC in the solid portions. But what we use in our practice, which is very useful, is MR spectroscopy. Why? Because MR spectroscopy is going to be abnormal in the periphery of a glioblastoma, as we know that this represents non-enhancing invasive tumor, while on metastases, the white matter adjacent to the ring-enhancing lesion actually represents vasogenic edema. So MRS should be normal in the context of metastatic disease. And of course, if we're dealing with multiple lesions, we have to think about metastatic disease. So this is an example of an enhancing lesion in the right frontal lobe. We used multivoxel MR spectroscopy, and you can see how the voxels that include the enhancing lesion show this inversion of Hunter's line within increased choline peak, decreased NAA, increased choline to creatinine ratio, and increased choline to NAA ratio, which is a signature of malignancy. But if we look immediately in the white matter adjacent to that lesion, we see that Hunter's line is preserved with a normal peak of NAA and normal peaks of creatinine and choline. So we find MR spectroscopy very useful to make the difference between glioblastoma and metastases when we have a single ring enhancing lesion. What else is important to differentiate the metastases from? Of course, abscesses. Here we have two patients with ring enhancing lesions. In this case, we can use diffusion, right? The patient on the left has no restricted diffusion. In the center, the other patient shows restricted diffusion. So very easy. Of course, this is metastases. These are abscesses. So again, just like in the previous case, what can we use to make the difference between the two? Here it's a little bit easier. Not always super easy, but easier than the previous comparison. Perfusion is going to be high in metastases. It's going to be low in abscesses. Of course, in the majority of cases, perfusion, we're going to have restricted diffusion in the center of the lesion in the context of abscess, while perfusion is going to be, diffusion is going to be facilitated in the context of metastatic disease. So this is just to show you the typical imaging findings of an abscess using advanced imaging as well. We have here a ring-enhancing lesion that shows low signal intensity of the capsule on T2 due to the presence of collagen and free radicals. This is the classic enhancement of the capsule on T1 post-contrast, very smooth and discrete enal margin. Of course, we're going to see restricted diffusion, and perfusion is low, so very useful to make the difference with a metastatic deposit. But we have to be careful because metastases can also show a restricted diffusion that can actually mimic abscess. Look, this is a lesion with significant central restricted diffusion that was initially thought to represent an abscess, but when you look at the pattern of enhancement of the T1 weighted sequence, it's not enhancing like an abscess, and actually this was a metastatic deposit from adenoCA of the lung. So be careful because in certain cases where there is hematoma or viscous mucin, where the metastases are coming from adenoCA of the lung or the colon, they can mimic abscesses. Okay, let's, in the next 8 minutes, let's focus a little bit on the role of the goals of treatment in these patients with metastatic disease. So, of course, the idea will be to control and or relieve neurological symptoms, and this is going to depend on all these variables. So some lesions clearly will need surgery, like this patient with this enhancing lesion in the superior aspect of the cerebellum, significant mass effect and edema leading to herniation. We see that there is non-communicating hydrocephalus with imaging signs of transependymal flow of CSF. Of course, this patient is going to need decompression of the posterior fossa, but also a ventricular drain. Different from this patient with this smaller lesion with a lot of edema that would benefit from treatment with steroids. So these are this is the main line of treatment for metastatic disease. Steroids, of course, indicated in symptomatic patients. It improves the symptoms in most of the patients with vasogenic edema, decreasing significantly in the first 3 days. And anti-epileptic drugs are indicated also in symptomatic patients, but also in the context of perioperative prophylaxis, as it decreases the chances of seizures in up to 50% of patients. And of course, anticoagulation due to the risk of thromboembolic disease that is increased in the context of brain malignancy. So in terms of radiation therapy, as you know, we have two main options. One is whole brain radiation. With whole brain radiation, the local control is modest, around 60%. Here the idea is to deliver low doses of radiation, but using multiple fractions. And the main indications are going to be multiple meds, usually more than 4, multiple beds with a poor systemic control, so metastases elsewhere, or multiple meds that are too large for SRS or stereotactic radiosurgery. The big problem with radiation, with whole brain radiation, is that these patients, most of them end up developing cognitive decline that could be significant, and this is the major concern. The other type of treatment is SRS, stereotactic radiosurgery. As you can see here, the local control rate is way higher. The dose is going to depend on the size of the lesion. See, the smaller the lesion, the higher the dose. The indications are going to be the presence of a single metastatic deposit, but also oligomets or multiple mets. Initially, it was said that they needed to be less than 4, but in our institution, we have treated up to 12 lesions with SRS, and this is becoming more and more common. Complication of radiation of SRS, 2 to 8% of patients may develop radiation necrosis, which is the most common complication. So here we have a patient with a single metastatic lesion measuring between 3 and 4 centimeters in the left cerebral hemisphere. You see the planning of treatment, and the patient was delivered a single fraction of 18 gray, and you can see here how the lesion has decreased in size significantly after 2.5 months, and after 4 months of treatment, you see that the lesion has completely melted, has responded well to treatment with SRS. And this is one of the examples that I wanted to show you. This patient had 8 metastatic deposits. All of them were treated with SRS, and the patient did very well. So with radiosurgery, really, the goal is to ablate the tumor, to melt the tumor completely. As you've seen in these examples, it uses higher doses, about a low number of fractions, while in radiotherapy, the idea is kind of to sterilize the brain with cumulative doses of radiation, so way more fractions, but at lower doses. So what happens after radiotherapy? So here we have a metastatic lesion in the left basal ganglia, so the patient receives radiation, and initially what's going to happen is the lesion is going to increase in size, and there's going to be associated vasogenic edema. Then over time, the lesion starts to decrease in size, and central necrosis develops, and edema starts to decrease as well, and late we're going to see that the lesion has significantly decreased in size and edema has completely resolved. So let's look at that with a real example. Here we have this patient with a metastatic deposit in the right cerebral hemisphere, received radiation therapy. You see how at 6 months the lesion has increased in size and there is significant edema, so there is reaction after treatment, but at 9 months you see how the lesion starts to decrease in size. You see the progressive decrease in size of the lesion and the resolution of edema. So increasing the size of the lesion and increasing vasogenic edema can happen in 1/3 of patients. And actually that means that the treatment is working, at least briefly, and is due to inflammatory response to radiation. And here we have another patient with a metastatic deposit in the left frontal operculum. We see that there is a significant vasogenic edema. The patient receives radiation, and you see how initially the lesion decreases in size, edema resolves completely, but over time we can see how the lesion starts to increase in size as well, changes in appearance with that Swiss cheese appearance that we know happens in radiation necrosis, and signal changes start to appear as well in this patient with treatment-induced necrosis or radiation necrosis. Interestingly, these patients are often non-symptomatic despite the appearance of these lesions. And here we have another patient with metastatic melanoma, 2 enhancing lesions in both frontal lobes, received radiation treatment, right here SRS, and you see how over time the lesion starts to increase in size, again starts to change in appearance with some sort of Swiss cheese appearance, but we're never certain, is this true radiation necrosis or are we dealing with recurrent disease? So in these cases we can use diffusion. You can see that in this particular patient, the center of the lesion was showing restricted diffusion and perfusion was low. Given the appearance on conventional imaging and the low perfusion, we thought that this was indeed a post-treatment change, so radiation necrosis, and the appearance on diffusion is very interesting, and this has been described as the three-layer pattern of restricted diffusion in the context of radiation necrosis. This was published first in European Radiology back in 2013, and the concept is very interesting. The first layer is what we see as the ring of enhancement that represents inflammatory change. Then the second ring, which is exactly what we saw in our case, is coagulative necrosis that restricts, and then if that progresses to liquefactive necrosis, that's going to be, this is not going to restrict on diffusion, it's going to be facilitated diffusion, and this is what is known as the three-layer pattern. So in summary, we have reviewed the role of conventional and advanced imaging techniques for the diagnostic of brain metastases. You see the importance of using MR perfusion and MRS in these patients because it's very helpful with the differential diagnosis. I would like to thank Dr. Castillo and Dr. Sinclair for providing some of the images that I have used today. Thank you very much.